Hello, everyone, and good morning from San Francisco. Welcome to our webinar, Moving Against Cancer, Community Solutions to Address Disparities. This webinar is being hosted by the Asian and Pacific Islander American Health Forum and the Asian and Pacific Islander National Cancer Survivors Network. I am Trish Kema. I am with the Chronic Diseases Program here at the Health Forum, and I will be your facilitator today. So just before we begin, I wanted to go over just some housekeeping items and share information on how you can ask questions through GoToWebinar. On your control panel, you should see the at the topmost, the Grab tab, which is the short set of the buttons here, and at the very top is an orange or a red arrow, and this automatically collapses to your right after approximately 10 seconds. So you would have to click that arrow at the very top to open and close your control panel. And on your control panel, highlighted in red, is the questions pane, and I would like you to type in your questions and for any questions that you may have throughout the presentation. I highly encourage you to ask us any questions if there's something that you wanted more information on from any of the presenters or something that you wanted to follow up on. And also, we will be recording this webinar, and it will be uploaded onto our YouTube page, so you can see the address on your screen. And for those of you who would like PDF copies of today's presentations, because we're sharing really good information today, please let me know by typing in your email address on the questions pane. So that's all I have for housekeeping items. Again, this webinar is hosted by the Asian and Pacific Islander American Health Forum and the Cancer Survivors Network. So founded in 1986, we are a 25-year-old organization which influences policy and strengthens organizations and their communities in order to mobilize Asian Americans, Native Hawaiians, and Pacific Islanders to advocate for their health and well-being. We are headquartered here in San Francisco with a Washington, D.C. policy office, and we have relationships with many, many community-based organizations from around the nation. Our community-based partners are some of our presenters today. And we engage in policy analysis and advocacy on the federal and state levels, and we train and provide technical assistance for communities in the areas of policy, organizational capacity building, research, and communications. So the Asian and Pacific Islander National Cancer Survivors Network is a network of cancer survivors, their family members, healthcare providers, researchers, health advocates, health departments, community members, and organizations who are concerned about cancer and survivorship in the Asian American and Native Hawaiian and Pacific Islander communities. On your screens, you can see our founders who are Susan Shinagawa and the late Reverend Frank Chung. And the mission of the Cancer Survivors Network is to minimize the burden of cancer and improve the quality of life of Asian Americans, Native Hawaiians, and Pacific Islanders by dispelling myths, reducing disparities, and providing hope. So we currently have about 500 organizational and individual members, and it's free to join our network. And if you are a healthcare provider, a public health professional, or advocate and survivor, we highly, highly encourage you to join our network. It's very easy, and all you need to do is just visit that page with the URL link below, apiahf.org/APINCSN/membership. And you can also sign up for our listserv through that page. So again, the Health Forum is a current grantee of the Centers for Disease Control and Prevention, and we are very, very fortunate to have an amazing set of speakers to join us today and lead us through this informative session. For today's webinar, we have Roxana Bautista, who is the Network Development Director here at the Health Forum, and she will share information on Asian American and Native Hawaiian Pacific Islander demographics, talk a little bit about the impact of cancer on API communities and share the value of and the need to disaggregate data. Next, we have Dr. Connie Nguyen Trong, who is in research in individual and family symptom management and a postdoctoral fellow at the Oregon Health and Science University School of Nursing. And she will talk about the value of using community-based participatory research and working with underserved communities. We also have Tuyen Tran, who is the Outreach Project Manager at the Providence Cancer Center, and she will talk about strategies and best practices on how to work with emerging and underserved communities. And finally, we have Reverend Joseph Santos Lyons from who is the Development and Policy Director at the Asian Pacific American Network of Oregon, and he will be sharing valuable information on the implementation and impact of healthcare reform and the Affordable Care Act. So we have a really great information to share with you today, and for your future reference, because we do have data that we will be sharing with you, this will be recorded. Again, input and type in your email address so that I can share if you want a copy of the slides. And I know that we're sharing best practices from community partners in Oregon, but know that, of course, the information can be applied across states and communities across the country. So with that said, I want to begin the presentation by turning it over to Roxana. Rox, you may begin at any time.
Hi, everyone. My name is Roxana. I'm going to start off the presentation today talking about how the Asian American, Native Hawaiian, Pacific Islander communities look nationally, as well as in Oregon, and some brief tidbits about cancer and cancer facts, and then our next presenters will be giving more details. So just letting you know, so with our communities, the Asian American, Native Hawaiian, Pacific Islander communities are definitely growing. Between 2000 and 2010, the Asian American communities grew with a 46% increase, and our Native Hawaiian Pacific Islander communities grew with a 40% increase. And the communities that make up Asian American, Native Hawaiian Pacific Islanders are so diverse. As you can see from the slide, there's so many different ethnic and cultural groups that make up the Asian community as well as the Native Hawaiian Pacific Islander community. Many of those communities are also foreign-born. Asians were 60% of them are foreign-born as of 2009. 12% of Native Hawaiian Pacific Islanders were foreign-born as of 2009 as well. And we just have a multitude of distinct, specific Asian and Pacific Islander languages and dialects. And so just wanted to share to kind of set the tone for the next data slides I'll be sharing. So Susan Matsuko Shinagawa is a co-founder of our Cancer Survivors Network. And when she discovered a lump in her right breast, and then she went to her doctor, and the response by the doctor when he refused to do the biopsy on the lump, he said to Susan, "You're too young to have breast cancer. You have no family history of cancer, and Asian women don't get breast cancer." And after seeking a second opinion and obtaining a breast biopsy, the second surgeon told Susan, "You do have breast cancer." And so this is, I think, as Susan has been working around advocacy, especially around data and resources for the Asian Pacific Islander community, I think now she's really truly understanding why the first doctor said Asian women don't get breast cancer, and I'll show you in the next slide. So often, a lot of how data is collected and reported is the Asian Pacific Islander community, while it is so diverse, as shown in the previous slides, a lot of the data is very much lumped together in not even a separate Asian or Pacific Islander categories. They're lumped into one category. And even in this slide, and the next slide I show you, it shows that the cancer incidence is lower for Asian Pacific Islander men and women because it's lumped together when compared to other communities. And if you look at the citation on this slide, it's 1997 to 2007 and 2010, and based on the Office of Management and Budget in 1997, their directive number 15, they said that they wanted federal statistics and administrative reporting to show that Asian or Pacific Islander category to be separated into distinct separate Asian category and the Native Hawaiian or other Pacific Islander category. And so that was a directive in 1997, and we're still seeing some data that is still lumped. So just to paint the picture of this is probably why, as physicians may be saying, even today, Asian women don't get breast cancer because look at how the data looks. Okay, we'll go. And then this is just a similar data in terms of cancer death rates and how much it's even lower in terms in comparison to incidence. So again, the lumping of Asian Pacific Islander into one category really masks the differences. And then I'll show you later on what it looks like when it is disaggregated. So definitely cancer does impact our communities. There are certain cancers that are more predominant in Asian Americans and Native Hawaiian Pacific Islanders compared to other communities, such as stomach cancer, liver cancer, nasopharyngeal cancer, and cervical cancers. Also, in this last bullet, it shows that our women are 30% less likely to have breast cancer as white women, but breast cancer is still the top cancer for our Asian Pacific Islander women. And specifically, there are some higher breast cancer incidence rates in the Filipino, Japanese, Native Hawaiian, Samoan, and Tongan communities. Also, with lung cancer is the leading cancer killer in the U.S., and it is one of the leading cancer killers in every racial ethnic group. Specifically for the Asian Pacific Islander and Native Hawaiian communities, lung cancer takes more lives than liver, colorectal cancers combined. And we'd be happy to also share some more resources if you're interested. We have been working with the Lung Cancer Alliance on some information, sharing information about lung cancer screening and some data around lung cancer. So I just wanted to share that. So the next slides really just are showing you how things look when it's disaggregated. I know it's very busy and it's very colorful, but when you saw the previous slides about how things were lumped in, this really shows that if you have the chance to have disaggregated data, you really can see that some cancers are definitely higher in specific Asian communities versus Asian groups. So such as prostate cancer is high in a lot of the different Asian male groups, as well as lung cancer, as I mentioned. Next slide. And same with cancers in our Asian women. Next slide. And then we actually sometimes are very lucky when we can actually get disaggregated Native Hawaiian Pacific Islander data. And so this is from a Miller article, which is the source at the bottom of the slide, which really shows how even compiling, it's not just 1 year of data, it's actually about 6 years of data in specific communities and states where there are actual substantial Native Hawaiian Pacific Islander communities, so they can actually get data. And so this is really key, especially for our Native Hawaiian Pacific Islander communities, to advocate for disaggregated data collection and reporting. And so you can see here how the different kinds of cancer affect our Native Hawaiian Pacific Islander men. Next slide. And then Native Hawaiian Pacific Islander women. Okay, and more, I didn't want to jump too much into the data because Connie and Tuyen will definitely share a little bit more. So I want to transition to show you how the makeup of Oregon is with our Asian and Pacific Islander populations. And so there was actually a huge growth of Asian and Pacific Islander communities in Oregon. And I found a really awesome infographic this morning when sharing the U.S. Census information on Oregon that from their Asian alone, so this chart shows about the different populations alone, so nothing in combination with other communities or similar communities. And so specifically with Asian, so there's 4.8% of the population of Oregon is Asian, and this is a change about increase from the 2000 census to the 2010 census, almost 40%, 39.4% increase. And then with the Native Hawaiian Pacific Islander alone communities, they make up 0.7% of the population in 2010, but the percent change increase from 2000 to 2010 is 68.1%. And so I'd be happy to, I actually bookmarked that article I saw with a really great census infographic. I'd be happy to share it with Trish to send out to the participants. Next slide. So Oregon's minority populations is also great because they have noticed that there's two specific concentrations where there is a large amount of minority populations. Washington County has eclipsed Multnomah County as the metro's area's most racially diverse county, with people of color accounting for 3 out of 10 residents. So that's really amazing to show within the last 10 years the growth of the different minority populations in the state. And then just further, just a little bit more granular data when we can find it, if you especially know how to maneuver the census a website. And luckily, I don't need to do that because we have our research and data team to be able to maneuver. But we can get specific data on the census to show not just Native Hawaiian Pacific Islander as a whole group, but also specific groups within the Native Hawaiian Pacific Islander community. So in Oregon, you have the Native Hawaiians alone in combination with one or more categories of the same race, or with other communities. And so you can see as the different communities are intermarrying and marrying with other races, how the numbers, when you check that box in census, really increase. And so I just wanted to just give you a picture of how really truly diverse the Native Hawaiian Pacific Islander community is in Oregon. And then next with Asian population, when we were doing our cancer state brief for Oregon, we actually had half the list because it was not as delineated in terms of, I guess, the Census 2000 data, that they would have this many different communities. But it just goes to show more people, there are either more check boxes or people are writing in what their communities are. And so this is really diverse. And so just letting you know, the source of this was Census 2010 data and the American Community Survey. They have 3-year and 5-year estimates, and it's going to be dependent on the availability of the data. So just wanted to paint that picture for you all. And then in terms of cancer, so cancer is a little bit harder to find. It might be, again, over a span of time versus span of a number of years versus just 1 year. And so the top 5 cancers for Oregon, for men and women in Oregon, are around prostate, breast cancer, lung, and colorectal and uterine cancer. And NOS means not otherwise specified. And so among our communities, the 5 leading cancers you can see here on that last column is prostate, breast, colorectal, lung, and thyroid. And then the same with the female cancer rate, breast cancer rate. You can see that only in terms of Asian Pacific Islander communities, we just have lung cancer as the mortality rate here in Oregon. And so we do need to have some more additional data to look at the following trends. And so just wrapping up, because I wanted to make sure there was enough time for Connie, Tuyen, and Joseph. We need to really understand the issues around our communities are so diverse. There's so many other issues that are possibly complicating the health issues and that influence social determinants of health, et cetera. And we also have said, aggregating our communities and lumping them into one category really masks the reality of the different disparities that are happening. And so what we want to encourage you all, though, is while it might be difficult depending on where you're located to get disaggregated data, this is where you can advocate. I always say it never hurts to ask and never hurts to try, that you can really advocate with your local health department, Cancer Control Coalition, or Cancer Registry, and find out, is there a chance that they can pool a number of years of data around the Asian Pacific Islander community. And you can also connect with local universities, such as the wonderful folks we have on the line, to see who might be doing CDPR, community-based participatory research in your communities and cancer, to try to access more data. And just wanted to just quickly say how important the Affordable Care Act is. There is a section 4302, which requires federal health surveys to disaggregate data across actual seven Asian subgroups and 4 Native Hawaiian Pacific Islander subgroups. And it actually is trying to now collect data based on sex, primary language, and disability status. So that's really key. in terms of what advocacy can do. And so that's on the federal level, and it really can be a model for you trying to also advocate to do that on the state level. And hopefully that's something you can work together with the Health Forum or APANO, as Joseph will end us today, as a way to really involve in how important data is for our community. So I'm going to hand it over to Trish to lead into the next speaker. Thank you.
Thank you so much, Rox. That's really, you did a wonderful presentation just painting the picture and how really diverse our communities are. The information that she shared, you can also, we have fact sheets for other states as well. We have people bringing those fact sheets when they do advocate, and they share those with their legislators, just, API demographics, and also a list of a directory of Asian and Pacific Islander community-based organizations in your state. So just go to our website. I'll share the information later at the end of the slide. So next is we have Dr. Connie Nguyen Trong. So Connie, you may begin at any time.
Good morning, everyone. It is my honor to present in terms of from a perspective of investigators, scientists, just around when we're trying to interpret where we're going to target study efforts and program research efforts in general. So next slide. Trish, I'm sorry, somehow I'm not. Okay, thank you. In terms of here, so I'm not going to specifically re-say what Roxana had brought up, and she's done a wonderful job with highlighting from Miller and colleagues analysis of the cancer incidence rates across from men and women at disaggregated. So it was helpful to see here. I just want to briefly highlight, again, just seeing in blue, that you can see here with prostate cancer, that's very, in terms of cancer incidence rates, it's really high across different racial ethnic groups. But when you're looking at the actual article itself, what's challenging is that the reporting areas that Miller and colleagues, the only available data that was available to them was from Atlanta, Detroit, Seattle, Puget Sound, and then California, Connecticut, Hawaii, Iowa, Kentucky, Louisiana, New Jersey, New Mexico, and Utah. And the question for me here is, what happened to Oregon data? And so that was a challenge, just trying to find at the state level if we had it available at the disaggregated among Asian American Pacific Islander groups. So this was a wonderful effort by Miller and colleagues, and the only available data they had was what was available through the National Cancer Institute Surveillance Epidemiology and Results Program. So that still remains a challenge in terms of trying to really be as diverse as we can, as well as being inclusive of a disaggregated level at the state level. Next slide. Oh, next slide. And for mortality rates here, just to highlight again what Roxana, but like for lung cancer mortality, we can see that that is relatively really high. And I want you to take a closer look, for example, at liver cancer. We see that it's relatively low among white non-Hispanic, but when you look at, for example, with Vietnamese here in the United States for men, that's, and also Samoan, a Pacific Islander group, as well as Korean, a subgroup, the mortality rate for liver cancer appears to be higher than that of Hawaiian, Filipino, and Chinese. So the value of disaggregated data is that we really get to see a closer look. Yes, numbers, if they're high, it's important to see, but we also want to take a microscope look in to see why is it that certain subgroups within the Asian American Pacific Islander groups is bearing a disproportionate burden compared to other API groups. And so this really brings on in terms of we need to really look at from a cultural perspective and other potential influencing variables that might be contributing to that. Next slide. And here, Roxana, she highlighted already regarding about breast cancer, so I have here in pink how that's really high in terms of new cancer diagnosis across these different racial Asian Pacific Islander groups. And when we take a closer look in, I want you to really looking at the small, it looks like really small little rectangles, the blue color for cervical cancer incidence. And at a glance, we're like, okay, well, maybe this might not be an issue that we need to target. Maybe it's only breast alone. But when you really, really come in with a microscope lens, you ask yourself, why is it that among Japanese and Chinese, for example, subgroups, relatively a smaller number, and then you have Vietnamese that's up there in the 16.8, and Samoan and Pacific Islander at 18.1. So you want to ask yourself, why is it that we're seeing this wide gap, but at a glance it doesn't look like overall that this is something that is concerning? Next slide. And here for mortality rates for women, when we look, and Roxana has highlighted already regarding about lung cancer being very high, but I wanted to point out let's take a microscope look in, for example, at cervical cancer. And at a glance, it looks like, okay, mortality rates appear to be low for cervical cancer. But then we want to ask ourselves, why is it, for example, Vietnamese is at 4.4? When we look at Chinese and Japanese, they're 2.2 and 1.7. So then we want to ask ourselves that very same question. I wonder why there is this gap, but when we look at it as an overview, it seems like it's not a high number, but until we take a more microscope lens at the data. Next slide. So in terms of getting into use of community-based participatory research, this was cervical cancer screening was identified as a priority problem among the Vietnamese community by health educators at IRCO, the Immigrant and Refugee Community Organization Asian Family Center. And in terms of looking at available data, when we look at it from a glance with Asian American Pacific Islander as a subgroup, we're like, okay, that is low in terms of adherence in the past 3 years having a Pap test compared to, for example, with white non-Hispanic and African American. Next slide. Next slide. And then the most available data that we were able to find was at the California state level, and we can see here that Vietnamese and Korean, compared to the other larger subgroups, even that much lower in terms of adhering to cervical cancer screening. Next slide. So I want to highlight pros and lessons learned from just trying to evaluate the state of the science. So in terms of what is even available, so for example, at my academic institution at OHSU, we have available, for example, Medline, the nursing database, as well as the psychology database, so that we can conduct a systematic review to see what is known about contributing factors to cervical cancer screening. And those kinds of resources may not be available at other organizations or institutions. So in terms of a partnership, that's where you want to really think about what are the skill sets and what are things that are needed from the community organization, as well as community members and leaders you're working with, and investigators, and who can examine the data and bring in different perspectives and knowledge. And so this is where the sharing of resources is very important, and having discussions about it. And one of the panelists, Ms. Duan, later will be talking, but she was also a community advisor on our study. So, next slide. So in terms of, we had to really carry out 3 years of prolonged engagement prior to conducting the study itself to really understand the Vietnamese community needs. And the emphasis was that the community members thought that it was very important that the Vietnamese community knew that I was a very nice lady. So even though I have a Vietnamese background and I spoke Vietnamese, but they didn't know who I was and what my purpose and why I was there and what I was doing. So this was a way for them to really get to know me. Next slide. So it was very helpful to have very diverse perspectives again from my committee, the investigators, as well as community members, and they serve in different roles as advisors, consultants, and liaisons to community organizations, as well as partnerships with organizations. Big team, yes. Next slide. And it was before when I was drafting the study aims, we had overall 6 aims, but it wasn't until when I worked with the community organization that was able to refine the study aims to really match with what it is that we felt was important to examine. So this is where that working together and really honing in how this aligns with the priority area. Next slide. And we wanted to use a model that aligned with the use of a community-based participatory research, and so using the ecological model and really examining from different perspectives of potential influencing variables on PAP testing. Next slide. And working with using a CBPR and working with community organization and members, we really designed a really rigorous approach to be culturally appropriate, language appropriate, in terms of how we went about conducting the study itself and also developing the instrument itself. And this was really important so that way we would have that community input as well, not just input, but also seeing if this is something that's feasible. Next slide. And so with mine, I was more than happy to take on that responsibility of reviewing the literature, of finding those different instruments to help measure the different variables that we were interested in from the organizational, community, and the interpersonal levels. Next slide. And we used a very innovative instrument translation approach, and traditionally, back translation procedures was viewed as being the gold standard, and you would see this in the literature as well. But we really wanted to have more of that discussion around how did we even come about deciding on what this translation meant and the meaning of that. And so we really was combining that CBPR approach as well as the United States Census Bureau's team approach to translation. And so we modeled where we had a committee as well as an external translation reviewer. So that way we also built in to make sure that we were translating meaningfully, but also being culturally sensitive to language as well. And then we were awarded the Western Institute of Nursing Award for the Kara A. Lindemann. And for purpose for sampling, yes, we used purpose sampling, and it really was helpful to work with him, Mr. Ji Chun, and we were able to collect from 12 different South Asian-based community, faith-based, and Vietnamese community organizations. Next slide. And so what I really just want to point out here is that we went beyond descriptive statistics in terms of frequency counts, which is important, and percentages, but really looking at the association of those different potential influencing variables with cervical cancer screening and looking at which variables were predictive of cervical cancer screening. Next slide. And then we were able to get granular level of data. So this is important at the percentage level, how many women had received a Pap test and how many had adhered to cervical cancer screening guidelines. Next slide. And then to highlight briefly among, we've had very great numerous different findings, and here among the 13 variables that we examined together, these were the 5 that remain significant predictor variables for having ever received a Pap test. Next slide. And then among the 9 variables that were found to be associated with cervical cancer screening adherence, these were the ones that remain to be significant predictor variables. So, for example, that doctor, nurse practitioner recommended having health insurance. And then to end, next slide, we did have issues with one of our variable was perceived benefits to having PAP testing. And these three that I highlighted in red and the one here on perceived common variables had a very low relationship with this respective concept. So I had recently worked with the community members, two of which are co-authors on the manuscript, to really identify why that might be, because we didn't find that to be a relationship with cervical cancer screening as well. So there's a measurement issue. And so that's something that remains to be a challenge, is just trying to find measurements that is culturally, cross-culturally transferable. So that concludes my presentation, and I'm going to turn it over to Trish.
Thank you so much, Connie. Again, for everyone, the slides will be available for future reference. If you do want to ask a question, please type in your question on the questions pane, and I'll be monitoring your questions, and we'll have time at the end to do some Q&A. So next is we have Tuen Tran from the Providence Cancer Center. Tuen?
Thank you, and good morning, everyone. My name is Tuen Tran, and I'm working at the Providence Cancer Center in Portland, Oregon. Thank you for giving me this opportunity to share with you all about our best practices of a community outreach program, Bridging the Gap Between Clinicians and the Asian Community, funded by the NCI Community Cancer Centers program. Next, please. And our program goal is working to improve access to target underserved population. And besides working with the Asian and Pacific Islander group, we're also working with other groups such as the African Americans, or Hispanics as well. And to reach our goal, we're using networking, like to find networking opportunities to local community groups or individuals who are interested in health prevention in order to develop the partnerships. And we can either work with their current program or provide sponsorship in terms of collaboration. And we find potential community partners, and we can learn about the community's demographics that will generate ideas for our outreach projects. And we can conduct like different outreach activities. Like I said, like we can participate in community events, or we can conduct our own educational activities. Next, please. And here there are some specific problems to be addressed. Educational and cultural gaps, like within the Asian community, about cancer awareness, screening, and prevention. Also, lack of connection between providers or those with health information and community members. Next, please. To start getting connection with our target population, first of all, we need to learn about those populations first. So we conduct like different activities, such as like we did the community needs assessments, health forums, and group discussions in order to, and we also invite like different community people to participate. We can identify about community health issues, cultural issues, and also sharing about people's health concerns or personal experience in healthcare. Also, throughout these groups, we can identify a key informant person, and that person will help us to get more access to the community. And based on the information we learn from the discussion, we can start conducting like different health educational workshops by providing presentation and to educate people about cancer prevention. And we believe that bringing many good benefits to community people is an effective strategy, such as like we offer educational workshops or free cancer screening. And like at our hospital, we have done several cancer screenings, like the skin cancer screening, oral head and neck cancer screening, or the breast cancer screening as well. And like we always include the educational piece prior to the screening, in order to educate people about the issues before they sign up for the screening. Next, please. And these are just the example of like different health workshops we conduct in communities. And we always try to provide our, invite our providers who can speak the same language with the audience. So it's easier for people to learn about the health issues. Next, please. And here just another specific example in working with community partners. Like currently we provide a small sponsorship to the Immigrant and Refugee Community Organization, that's called ERCO, to develop a training program that is called Train the Trainer to become a community health promoters. And our provider conduct, develop the curriculum and conduct a 4-week training to provide information about general cancer prevention, and follow up by the advanced training on specific cancer topics in order to provide more in-depth information. And after our community health promoters, and this is a very diverse group, so they will customize the materials, and they also need to translate the materials into their language, and then they can go back to their community and conduct the workshop on their own with our support. With the goal of this partnership is to raise cancer prevention and screening awareness in different communities. Next, please. And throughout the program, here are some of our success factors. We established strong correlation with different community groups. Now people start to come to see us and express their interest in partnerships. And we can also see the increased number of our attendees in our workshops and our different events. And the community people, they feel more comfortable to talk to our providers to ask questions. And a good thing here is we're lucky to have a strong support and engagement from our providers. They are willing to go out to different communities and conduct presentations at any time. And we can also see more underserved populations join into our screening events. Another important factor that we help to improve access to healthcare needs, like beside the educational workshops, we also provide a free basic health testing, free cancer screenings, and we provide different health materials, and we refer patients who don't have health insurance to our financial assistance program to get through the process if they got some abnormal findings after the screenings. And to measure the success, we usually do the evaluation based on the increased number of our patients or attendees. And for each event, we do the satisfaction surveys in order to get feedback from the patients to improve our future events. And especially with the presentation or educational workshops, we always have the pre and post test to evaluate the information people learn. Another fun activities, but we found out it's really good for the participants to memorize and to summarize about what they learned from the presentation by doing the question and answer contest. With this one, I would like to thank you, Dr. Connie Nguyen Chong, because we did the health event together, and she helped to coordinate our mini health info booth, and she suggested to use this one, and it was really effective. Next, please. So we successfully conduct our outreach activities in different communities, but we still got some challenges, like to motivate people, to get people interest and engagement into our outreach activities to raise cancer health awareness is still hard, and with many different reasons. And also, like Dr. Connie mentioned earlier, they build up trust and commitment, also really important, because people need to know who we are and what we need from the communities and what we can bring to the communities. And for some other challenges, I'm sure many of you here also encountered on workshop arrangements. like schedule for a speaker or find a location that is more convenient for the participants, not for us. But the most important issue is the budget for screening needs. Because whenever we offer the screening, we always have to consider about the next part, like the follow-up care for uninsured population. Next, please. And throughout the programs, overall with the lesson learned, like beside the events planning, like usually when we offer the educational piece, we always have to consider about other needs to make it more convenient for patients to attend to our workshops or our screening events. And throughout all activities, we learn some good information from different communities. And here's some specific issues we learned from the Asian and Pacific Islander groups, that healthcare is not their priorities. Usually their living conditions or finance are more important. And confidentiality issues, because the community is so small, so they're afraid of their personal information will be exposed, or they're not used to the preventive care. They just go to see a doctor when they're feeling sick or they have symptoms. And with other unmet healthcare needs, such as like lack of health insurance, because the majority of the community people that we're working with, they don't have health insurance, or they don't have the community health resources or other health information in their language, so they don't know like where to go to get to ask for help. And there are some misunderstandings between providers and patients due to cultural barriers or language barrier. There are some taboos or fear of talking about chronic disease in public, or they feel embarrassed about if they have like cancer. And with language barriers is another issue, because they don't understand about their current health conditions, and they can talk to their providers because they don't speak English, or they don't know there are screenings available in the community, or they don't even know like when they need to get screened for prevention. So those are just some lessons learned throughout our outreach activities, and we're still learning. So if you have any question, I'm happy to answer. And I think I'm almost running out of time, so I would like to hand it over to Chris again. And I also include my contact information for if you need to discuss more in later. Thank you.
Thank you, Quinn. Next, and our final speaker today is Reverend Joseph Santos Lyons from Apano. Joseph?
Hi, everyone. It's Joseph. We're really happy to have you on the call and the webinar today, and it's great to be a part of the panel with Dr. Connie and Ms. Twin. So I'm going to talk a little bit about the impact and of the ACA implementation in Oregon. But first, some background on Apano. We're a statewide community advocacy organization working with a whole range of Asian and Pacific Islanders. We've got over 1,000 community members who are engaged through Apano, and we host community forums, we do policy research, and then we mobilize our communities to do policy advocacy, primarily at the state and local level. Next slide. So really just first want to give folks some context for why we do health equity, particularly in the health reform sort of environment right now. And we sort of see three things that really matter. First is that race matters, that there are over 2 million Asian Americans who are uninsured. And if you dig down and look at specific communities, there are significant disparities in terms of who does and doesn't have access to health care. Also, language really matters. I think a really stunning statistic is that 9 out of 10 English speakers, folks who are native English speakers, lack proficiency in health literacy. And when you look at the language diversity and the English language learners within the Asian and Pacific Islander communities, we imagine it's even higher. And that finally, culture really matters, that healthcare access problems are often compounded by immigration, language, and cultural stigmas, and that we need to have culturally specific strategies to be able to address the health disparities that our communities face in cancer and in other health areas. Next slide. So we want to talk a little bit about Apano's advocacy agenda, and we work both with folks who join Apano and also with community-based organizations and other partners to be able to identify the issues that we think are important to our community and to be able to organize and educate folks to take action on them. We sort of have three sort of general sort of areas of focus. First is around really thinking about having policies that start with equity, that from the get-go begin to address cultural competency, accessibility, and affordability. And that we're looking at systemic change. So we're taking into consideration what's happening with national and local reform, including the health insurance exchange, which will extend coverage to over 600,000 uninsured Oregonians, and the coordinated care organizations, which is going to reform how over 600,000 folks who receive Medicaid have their health care delivered. So go ahead and go to the next slide. So just a few points about the impact of the Affordable Care Act here in Oregon. I talked a little bit about the health insurance exchange and the coordinated care organizations. Oregon's really on the leading edge of health reform, and the federal government recognizes that and is investing a lot of money in our state to be able to support the development of new health care delivery systems. So for example, they're providing nearly $2 billion over 5 years to support our coordinated care organizations. Also at the administrative level, and this gets more into sort of the details of issues that we work on, we're really interested in ways to better collect data, and we've been working with our Department of Human Services and Oregon Health Authority, which has established a joint internal policy on race, ethnicity, and language data collection, and we're hoping to see that become fully implemented and fully funded and then expanded to other agencies within the state so we really have accurate data. Next slide. So just these are some of the specific impacts on Asian and Pacific Islanders, that there are a number of folks in our community who do lack health insurance, who will be covered through the health insurance exchange, and that the legislation itself provides more support and sort of stronger standards for language access, for improved data collection, for building a more diverse workforce. But it takes really our community groups to sort of watchdog and really ensure that these things are being fully implemented. One example of where there's major gaps is that even though the state has requirements around data collection based on race and ethnicity, in many departments they're actually badly out of compliance and have not been able to even implement the basic national standards. So, we're really trying to be a resource to folks and also to make sure that folks are in full compliance with the ACA. The next slide. So this, I'm going to wrap up here in a few minutes, but wanted to make sure that folks know that there is a real need for both community and health professionals to serve on community advisory committees. And that research and experience really shows that when there is that context and the wisdom provided by community folks in terms of thinking about the delivery systems, that those really correlate with higher quality care and lower costs. And that there's a number of opportunities here in Oregon around participating in a community advisory committee, particularly with one of the local coordinated care organizations. We're working closely here with HealthShare, which is the Portland Metro Tri-County Medicaid CCO. But we're also engaging with the Health Insurance Exchange and the state's Health Equity Policy Committee. And so if folks on the call are interested and would like more information about these opportunities, would like to go through any training or get any more information, we're happy to help provide that. We're really excited to support more people, particularly in the Asian and Pacific Islander community, who want to participate in community advisory committees. So the last slide. So we're also a part of a number of advocacy coalitions locally and statewide. We're a part of a statewide health equity alliance that works with the Urban League, the Center for Intercultural Organizing, the Oregon Latino Health Coalition, and other groups. And that alliance works primarily on statewide legislation and helps to sort of coordinate and ensure that we're sort of in as much alignment as possible around a legislative agenda. And we know that that's really important because many of our groups are extremely small and are primarily run on volunteer energy. And so having a really strong and effective alliance helps amplify our voice. And then more locally, we have a HOPE coalition, which is a regional equity coalition of a number of community-based groups and health providers who are looking at strategies to advance health equity in the Tri-County area. And then we're also a part of several health reform collaboratives that are looking around policy change both at the administrative and legislative level. And these coalitions, if you're a part of an organization that is interested in getting more engaged, we're happy to connect you with any of these different coalitions. So next slide. So what's coming up next for us? The Oregon legislative session begins in January, and we will be tracking legislation. Right now we're not aware of any specific cancer legislation that's going to be introduced, but there is talk about some bills to continue to expand access to cancer screening and prevention. In the last session, we supported a bill, Senate Bill 433, that expanded screening and services for women who had breast or cervical cancer who were on Medicaid. And that was a really exciting victory. The legislature passed it and the governor signed it. And so now, any woman who is diagnosed with breast or cervical cancer who is on Medicaid will receive sort of the full treatment, and that there'll be no more folks who will be denied. We're also looking at the essential benefits package for the Oregon Health Insurance Exchange and really wanting to have the strongest benefit package available in the exchange, so we don't have folks in our community who are who are receiving the so-called bronze package of sort of really cheap health care, that we really think that health care is a human right and it needs to be provided at an adequate level to meet people's needs. And then we're also looking at how to provide more funding to support the training and development of community health workers. There's a goal to develop 400 community health workers in the next 2 years that the governor has set for the coordinated care organizations. And we believe that these are the folks who are going to be more connected to community, have more language and cultural capacity to engage with the diverse communities here in Oregon. And then lastly, we are preparing to introduce some legislation to improve data collection to be able to either study or implement a stronger standard to ensure that we are collecting race, ethnicity, and language across the state. That was my modified 6-minute version.
Thank you, Joseph, for sharing all that information. I know we're coming to a close, so we did receive a couple of questions from participants, but we don't have time to do Q&A. We will, however, email you separately and connect you with our speakers for those who ask specific questions. But please do stay connected. This webinar has been recorded for your future reference, and it will be available on our YouTube channel. Stay connected with fellow advocates and survivors by liking our Facebook page. And finally, subscribe to our listserv, because we do send a lot of research and funding and opportunities and through our newsletters. And we've had previous webinars before on just other, like on cancer survivors and also social media strategies and different really wonderful information. So please sign up for our listserv. And finally, it's free to join our membership for the Asian Pacific Islander National Cancer Survivors Network. If you are an advocate or working on cancer or cancer program, please join our network. And if you want to learn more how to become engaged, how to advocate for your community, how to get access to data, we can help you with that. And we have many relationships such as with Joseph and Twin and Connie and other wonderful professionals in public health from around the country. So we would be happy to connect you and help you join any legislative or policy committees, advisory committees, and working groups. So please do join us. So with that said, again, I have everybody's email addresses who have requested for slides. And if you have any questions, feel free to contact me. And again, thank you to Roxana, Connie, Twin, and Joseph for spending time with us today and for joining us in this wonderful session. Again, we look forward to staying connected with each and every one of you on the call, and we hope you can participate in future webinars. So you will receive a follow-up email which will have a 2-minute, really short survey from us, and this will really help us in informing us about our program, and also it's very important to us. So please do submit your responses to the survey. So thanks again, everyone. With that said, we look forward to staying connected with you, and this webinar is now adjourned. Thank you, everyone, and bye.